So this is me. I work both in the NHS as a consultant psychiatrist and here at Newcastle University, though of course everything that I say is from my viewpoint as a Christian and doesn't of course represent either the university's or the trust's point of view necessarily. So if we could have the next slide, please. Okay, so just as we move into this area, there's just there's a couple of main points I'd like to make, each of which is in itself a large topic, which I'm sure will be dealt with elsewhere in the course. But just important as we deal with the topic of mental illness that we remind ourselves who we are as human beings. We are neither, of course, merely spirits, or nor do we say that the spirit is the thing that really matters and we're just kind of entrapped in bodies, nor do we join with modern humanists, materialists, and say that we're essentially bodies from which our mind is a precipitate, that our mind is not a real thing that can be differentiated from the body. It's just a product of neuronal activity, nerve activity. So we do not adhere to that either. We know that we are both body, physical beings, and soul or spirit or mind, mental soul, spirit beings as well. And we know that as human beings then, we're joined together into then psychosomatic wholes, and that our mind, our spirit side, is continuously interacting with our physical, our body side, and in particular then the brain and the mind interact closely with one another. So what happens in the body always impacts the mind. What happens in the mind always impacts the body. There is this continual interaction between them. And this is, of course, especially relevant to mental illness, but it's true for any illness, and it's true for all our activities as human beings. Next slide, thanks. And then, of course, the second topic of relevance is the fact that we are made in God's image, in his likeness. Again, a large subject. But this is who we are as human beings. We are God's representatives serving him here as these spirit body, these psychosomatic beings. And we are made then to be like God, to live in relationship with God, and to live in relationship with one another, because we worship a God who has always been in relationships in the Godhead. Father, Son, and Spirit are relational persons. We do not worship a lonely God, a single person God. We worship a Trinity. And therefore, as people made in his image, we are relational beings. It is not good for man to be alone. And this is, again, so central to understanding mental illness, that being isolated, as people are sadly a lot at the moment, is extremely difficult. We're not made to be alone. When we isolate people in rooms in nursing homes, and we isolate people in their own homes, that's harmful to human beings, because we are relational beings. We are made to be in a series of relationships, of which marriage might be the most intense, but we have relationships of all levels, of different levels of intensity with other people. Those relationships get damaged by mental illness. Damage to those relationships in turn affects our mental and psychosomatic function. So this is who we are. We are image bearers. Next slide, please. And then the second key element of the many things that we could say about the fact that we are God's image bearers is that we were created to be, from Adam onwards, rulers on the earth, kings under God, and therefore to be active, to be working, to be doing things. We are not made to be idle. We are made to be active, yes, in relationships, but through, in all sorts of ways, serving him in the work that he gives us to do. This is again integral to who we are. Our creativity, our activity generally is an expression of our God-likeness. And again, to be indolent, to be restricted from doing things is harmful to us. And again, mental illnesses impact on our ability to do things, and therefore damage our ability to express our imageness. So just a few quick points that are important to get in our heads as we come to the topic of mental illness. Next slide, please. So mental illnesses then are holistic. if you have some kinds of physical illnesses, like kidney disease, for example, it doesn't impact us in the same way as mental illnesses do. Mental illnesses, by the fact they impact our minds, affect all that we are in a way that doesn't apply to physical illnesses unless they become spread through the whole body and in turn impact the brain and the mind, and therefore through that interaction affect the whole of our beings. But all mental illnesses affect us holistically, totally, and that's part of the reason, in fact I think probably the main reason why they're so damaging. They're not restricted. When you're mentally ill, you cease to be able to function as an image bearer of God. We'll see this in depression, we'll see it in a future talk in anxiety, we'll see it in dementia. And of course, because of the fact that we are relational beings as image bearers, when the person with mental illness is affected holistically, necessarily the whole of their being, that impacts on their relationships with other people, especially those close to them in their families. Mental illness inevitably affects these relationships in a much deeper, a much more profound way than physical illnesses do. If you've got a family member who's physically ill, it can create some extra work for you to do in caring and taking on other activities, but it doesn't directly impact on your relationship in the way that mental illnesses do, because mental illnesses affect us centrally to who we are, and therefore, because who we are is relational beings, it affects how we relate to those close to us. So understanding who we are as psychosomatic beings and as image-bearing beings helps us to understand why mental illnesses are so devastating for people who have them, and then for those who live with them, love them, and care for them. So next slide, please. So this is a quote from a few years ago. John Horder, I think by this time was retired, as had been president of the Royal College of General Practitioners, a GP. So he said he had suffered several serious illnesses, but he said, if I had to choose again, I prefer to avoid the pain of depression. It's a surprisingly physical sensation. That's what people say. It's this impact of mind on body. It's not just a mental thing, as it were, because we're wholes, psychosomatic wholes. Surprising resemblance to coronary pain, that's heart pain, because it too is total. It cannot be relieved quickly, even threatens life. It is oneself and not part of one's machinery, a form of total paralysis of desire, hope, capacity to decide what to do, to think, what to feel, except pain and misery. So it's this pain and misery that engulfs people with depression, that impacts on them in this way. He had severe renal disease, he had renal colic, which is extremely awful pain to have. He had heart attacks, really bad cardiac pain and illness, depression much worse. Next slide, please. Lewis Wolpott was somebody I studied at medical school, an embryologist, professor of embryology. And he had a profound depressive illness as well, and he wrote about this. He said, it was the worst experience of my life, more terrible even than watching my wife die of cancer. I'm ashamed to admit that my depression felt worse than her death, but it is true. I was in a state that bears no resemblance to anything I'd experienced before. It wasn't just feeling low, depressed in the commonly used sense of that word. I was seriously ill. Depression is not the same as normal sadness. Okay, yeah, next slide, thanks. So then, what is mental illness? Before we come to depression, just sort of ask more generally, what kind of thing are we dealing with? So next slide, please. So this might not come as a shock to people in this room, but there is a serious point behind this. And I'll say, why is this not true? Why is this not true? And there is a serious point here. If you go to the next slide, please. So in the British Medical Journal, the BMJ as it's now known, a few years ago, then they had an article, or a series of articles, looking at the new way in which mental illnesses were being categorized for diagnosis, the Diagnostic and Statistical Manual, DSM. It's a kind of Bible for diagnosis and psychiatry. And 4 of these are listed in that manual as supposed mental disorders and mental illnesses. And one is a fictitious one that was invented for this article. I use this in teaching on diagnosis in psychiatry. So, which one of those is not an official mental illness. Now don't worry, I'm not going to ask you to put up your hands or anything, and I can tell you that psychiatrists don't get this either, okay? The answer is the top one was the invented one, but the rest are listed. Now none of those are actual illnesses, okay, in my opinion. Next slide, please. So this is why it's a serious issue, isn't it? So you could find other quotes. This is from Khrushchev, when they were locking up people on the grounds of being Christians in Russia. Today we will have brothers, sisters imprisoned in China, North Korea and such places. And I presume there are people in there on the grounds that they're Presbyterians. And they're locked up on the grounds that Presbyterianism has been declared to be some kind of mental illness. That's why I'm saying there's a serious point to understanding what we mean by mental illness. As a psychiatrist, I could lock you up. Well, not quite, but I've got authority from the Secretary of State to fill in a form and declare that you should be treated in hospital where you'll be locked up on a ward. Now, I can't do that on my own for good reasons, but the principle is that our country, like other countries, gives powers to psychiatrists to lock people up who haven't committed any crime, but because they've got mental illness. Now, that's necessary because of the nature of mental illness, but it's also, of course, vulnerable to abuse, as in China today, as in Russia in the past, and so on. Okay, so next slide, please. So what is a mental illness? This is in my book where I go into it in much more detail. So if you go to the next slide, please. So the first part is a behavioural syndrome. That's generally true how we do diagnosis in medicine. You look for a cluster of signs and symptoms, features that run together as a syndrome then. Next slide. But you could define Presbyterianism as a syndrome, or Anglicanism as a syndrome, because you could say that here are the features of the Presbyterian syndrome. They carry out infant baptism. They worship on the Sabbath, or they keep the Sabbath. They sing psalms. They wear suits to church. The women wear skirts and dresses to church. And you know what I mean? You could go on, you could define a syndrome that would identify somebody reasonably accurately as likely to be a Presbyterian and so on. So the syndromal thing is why you can end up with things like pyromania and caffeine intoxication, because you can define any behavior that political, religious, sexual, whatever, and say there's the syndrome because this is the kind of pattern of behavior. And we all have patterns of behavior, Baptists, Presbyterians, we all have patterns of behavior. That doesn't make us ill, it's just who we are. That's just being human, okay? Next slide, please. So illness is different because illness is a response to some objective cause or causes. This is derived from the National Institutes of Health definition of illness. So the key thing is that either due to an external cause, like a coronavirus, or an internal cause, like a genetic mutation or something, then you get a specific cluster of signs and symptoms, a syndrome that we define as a mental illness, but there needs to be a response to an objective cause. And what you don't have in Diagnostic and Statistical Manual is this. You do not have the necessity for a response to an external or internal cause. It is purely descriptive, and that's why all sorts of things can be defined as mental illnesses in what frankly is a very arbitrary way. And I've joked in talking, you could just invent things. You can have hijacking disorder. You can have road rage. And some of these you actually hear about in the media as if they are supposed to be mental disorders. All they are patterns of behavior. They're not due to a fundamental change in the human being due to an external cause or an internal cause. Next slide, please. Now, it's important that we also, in medicine, generally look for an impairment in functioning, that the impact of whatever's going on that causes the syndrome, that causes the change in us, external or internal, affects our everyday function. And this is certainly true of mental illnesses. We all get down from time to time. We all get anxious from time to time. That doesn't make us ill at that point. If your anxiety or depression is persistent and more severe, and it affects your ability to carry out all your usual everyday work and activities, that's when it kind of crosses by convention into what we'd say is an illness. And again, that's generally true in medicine. Somebody can have pains and problems with their eyesight, pains in their joints. It becomes an illness when it's problematic, when it affects functioning. And finally, next slide, please. So because of the potential for abuse, definitions, including DSM, do have this sort of statement included to make sure that you don't do in this country what's done in other countries, sadly, where they won't adhere to this. So, political, religious, sexual patterns of behavior are not able to be defined as mental illnesses. Next slide, please. Okay, so with that background, we move then specifically to depression. Next slide, please. So, William Styron is a novelist, award-winning novelist who also had depression. I've not read any of his books apart from this one. So he said, my conviction is that normal sadness is to depression what normal growth is to cancer. It's fundamentally different. Next slide. So for diagnosing depression, we look for 9 core features. This is the syndrome then, these 9 features. And you look for 5 of these to say that this would be a significant, or likely to be a significant depression, that is a depressive illness. So obviously sadness, a change in mood to depressive mood, but these other factors, you're no longer able to enjoy yourself, you lose your energy, you lose your weight because you lose your appetite. There are these fundamental changes in a loss of appetite that is quite profound for people who just simply have no desire to eat at all. And it's very difficult to persuade people to eat. They can't sleep. Again, not just a disturbed night, but night after night of horrific inability to sleep, filled with horrible pessimistic thinking. Your concentration is impaired. Suicidal thinking is common, not universal, but very common. And then there's a psychomotor, so it affects our bodily function as well. So psychomotor means the mind affects our movements, our motor movement function in the body because we're psychosomatic wholes. Next slide, please. Now, depression is a terrible term. I'd far prefer it to be called melancholia, which was the old term that was used till depression came along. So this is Lewis Walcott. Again, severe depression borders on beyond description, not just feeling lower than usual. It's a quite different state, a state that bears only a tangential resemblance to normal emotion. Depression, yes, it's about a profound sadness, but it's much more than that. Just try to think of it as sadness doesn't do it justice. This is what Lewis Walcott's trying to capture. So he says, it's not just sadness and normal emotion that's gone wrong. It deserves some new and special word of its own, a word that would so encapsulate with the pain and the conviction that no remedy will come. We certainly could do better than this word with a mere common connotation of being down. It's not just being a bit down. Next slide, please. So depression, a wimp of a word. So depression, I just like these quotes from Styron. He's a novelist, so he can write well. Depression is a word that has slithered through the language like a slug, leaving little trace of its intrinsic malevolence and preventing by its very insipidity a general awareness of the horrible intensity of the disease when out of control. So it's this thing, it isn't just being down. That's why you don't like the word depression, it just says you're a bit down. Melancholia would appear to be a far more apt and evocative word for the blacker forms, because of course melancholy is from blackness, but it was usurped by a noun, depression, with a bland tonality and a lacking any magisterial presence, used indifferently to describe an economic decline or a rut in the ground, a true wimp of a word for a major illness. Okay, next slide, please. So trying to make the point, depression is not just sadness. It's not just people being a bit down. It's a profound and horrible illness. Now, there are lots of things that are called depression. Okay, there are lots of things. Depression has become a huge umbrella under which all sorts of things that aren't illnesses nestle. So as I said, normal sadness, we all get down. Life is full of trials and difficulties, and we have normal reactions as image bearers to that, and normal emotions congruent, consistent with those experiences that make us feel sad. That's not depression. Spiritual depression is a term that's used. There's an article I wrote earlier this year in the Banner of Truth magazine on to understand spiritual depression, what it is, and it's not depressive illness. It's something distinct. Then you get depression when you're sick because we're psychosomatic holes. If you've got a bad physical illness, you feel down a bit. That's fine. That's normal because we're human beings who are psychosomatic holes. That's not what we're talking about here. Then again, grief is part of normal experience in this fallen world where we lose people we love. We suffer with that. We feel profoundly sad. We have grief. Again, it's different. And then there's burnout, which I've spoken on as well and written about. So burnout is a kind of exhaustion syndrome rather than a depression. Depression is a kind of feature in the sense that sadness is part of it, but it's not fundamentally what's going on with burnout. Burnout is psychosomatic exhaustion. Next slide, please. So what I want to focus on is depressions that come into contact with medical services, if you like. So at the top, psychotic depression is the most severe form, moderate depressive illness, and psychosomatic. So what I call psychosomatic, historically, this used to be called neurotic depression, but of course neurosis and the adjective neurotic are kind of words that you're not supposed to use nowadays because they're seen as pejorative. But if you read in books about people who are neurotic, it's this kind of area. And now all these sort of depressive illnesses, they're long-term conditions. Medicine has lots of long-term conditions. Depression and mental illnesses generally are not short-term problems. Next slide, please. Okay, so this is Timothy Rogers, who was a Puritan, 17th century Puritan, who had depression and wrote about this, melancholia as he was called at the time. And he makes the important point here about this thing about you can't just kind of shake yourself out of it. You can't just pull yourself together, as the horrible phrase has it. So it's commonly said by others who do not know what melancholy, that is depression, what melancholy is. Why do you think so much? Divert yourselves. Think of something else. But it's no more possible for people where this disease comes with violence to divert their thoughts than it is possible for a man with a broken arm or a leg to walk and act as he used to do before. They can think of nothing but what they do think, just as a man with a toothache cannot forbear to think of his pain. Though others urge us to rule our thoughts, it gives no relief, but only adds to our misery to be frequently urged to do that which we cannot do. So please don't go and tell people with depression or other mental illnesses, what you need to do is, and that's going to sort things out. It's not possible. Next slide, please. So these are sort of three types of depression, if you like, that I've just said we'll briefly consider. So the outer circle, this is one way of seeing this, okay? So depression is one thing, one illness, one syndrome arising from that, with the psychosomatic, the mildest form, obviously having the most number of people, and these are supposed to be kind of annual numbers or percentages in the population. So very high. Now I think this is too high, but these are typical figures that are given. And then the moderate ones in green, and then the most severe form is in the central circle, the 0.5%. The 0.5% is a robust kind of figure. This is essentially those who end up under people like myself and usually end up in hospital. The larger figure, the 2 to 3%, a lot of these people would come to me as a psychiatrist. A lot of them will be managed by GPs in primary care then. And the wider circle is the one where some of these people may come into contact with general practice and some of them don't. But you in the ministry, look at people who might actually be in the ministry, you in the ministry then encounter all these people, and they're the kind of people you can help. So it's not that you can't provide help for those in the other two circles, but they need medical help in a way that I don't think the outer circle does. Next slide, please. So I suppose I would see it like this. I don't think that there's one cause for depression. Now, it's an academic debate that's long-standing in the field about this, but I think that melancholy, severe depression is a separate entity. There may be some overlap. Certainly it can be difficult to differentiate with the much wider psychosomatic and neurotic type of depression, but that big circle, I think, is generated in a different way. The causes are different. That doesn't mean I think it's wrong to say they're ill, and it certainly doesn't mean it's wrong to say, it would be wrong to say they don't need help, because they certainly do, but I think they are fundamentally different. But that's really another topic beyond what we'd look at today. Next slide, please. So the worst form of depression, psychotic depression. Elizabeth Wurtzel obviously suffered from this. That's the thing I want to make clear about depression. It's got nothing to do with normal life. It's fundamentally different. So I'm giving you a lot of quotes to make the point. These are people, male and female, young and old, from hundreds of years ago, from today, all sorts of backgrounds, academics, GPs and so on, who've had this, who are trying to get across the message this is something fundamentally different. So this is the thing I want to make clear about depression. It's got nothing to do with normal life. In the course of life, there is sadness and pain and sorrow, all of which in the time and season are normal, as I was saying. They're unpleasant, but normal. Depression is altogether different. It's in an altogether different zone because it involves a complete absence. An absence of affect, an absence of feeling, an absence of response, an absence of interest. But for all intents and purposes, the deeply depressed are just a walking, waking dead. Now, I think this applies to those two smaller circles, but it's important that it isn't really actually just sadness. I think absence captures it better. There's just no feeling. There's just this awareness that I ought to feel something as I'm talking to this person. As I engage here with my husband, I should have a reaction, but I don't. I'm completely devoid of feeling. And it's this profound emptiness, this absence of emotion that is so hard for people with depression. So that's why it's trying to capture this is somewhat different from sadness. It's not an extension of sadness. You kind of lose emotion altogether. Next slide, please. Okay, so just briefly then, because people like this, you have them in your church from time to time, they need people like me, they need secondary care, they need hospitals, they need treatment. So these are the people I might have to detain and bring into hospital, and have done so under the Mental Health Act. They need to be hospitalised, sometimes sectioned, that is brought in under the Mental Health Act, a section of the law, the Mental Health Act law. They need antidepressants. They may need other drugs, including antipsychotics, and they often have electroconvulsive therapy. ECT is still the best treatment that we have for depression. It is safer than antidepressants and is a brilliant treatment for people who are severely ill with depression like this. It's become horribly politicized and sadly can be difficult for people to get hold of sometimes, which is horrendous given how effective it is. And we in psychiatry have a kind of ongoing battle against people who are trying to get ECT banned. We need ECT, it's life-saving, literally, for people with severe depression, where antidepressants don't work in a lot of these people. Okay, next slide, please. So, in the ministry, in our church, how do you help these people? So I was saying these are fundamentally seriously ill people. They need secondary care, they need hospitals. So go and visit them, okay? I know, it's easy for me to say, I'm used to going on psychiatry wards. I know they can be a bit spooky. But please do make the effort to go and visit. Human beings, like the rest of us, they're ill and they're suffering. So do think about them, pray about them, visit them. When you visit somebody with depression, when you're in contact, don't be afraid to ask about suicidal thinking, okay? It's very difficult, especially for Christian people, to confess that they're thinking that they wish they were dead, that indeed they're having thoughts about killing themselves, okay? Now, this is an expression, if you like, of how ill they are, how depressed they are. They're so out of it, it's so miserable that they want to be dead. Even as Christians, okay? And as Christians, they will feel particularly bad about thinking like this. So, but by asking, you're showing that you have an understanding of what they're going through. You're trying to understand how bad it is for them. You don't need to worry about giving some special answer. There isn't a special answer. But asking the question, showing by that and by a response that you're trying to understand how bad it is, and just making a comment like that, that must be horrendous. That must be horrible if you're feeling like that, okay? That is helpful, okay? There's nothing special like that. Just do that. And do ask them relatedly about, their walk with the Lord, their faith. related to this, all sorts of horrific sense of guilt and self-blame for what they're going through. Somehow it's their fault. Somehow how they're dishonoring the Lord by being like this and so on. But they're ill. It's not their fault. They're ill. So, ask about these things. Ask about their guilt feelings. Try and encourage them, to pray, to sing praise. When you're profoundly depressed, you can't really do it, but you could try, and if you can, not like me, I can't sing, but if you can sing, sing something with them. Read a hymn to them, something that will remind them of fundamental truths about our salvation in Christ. And encourage them, pray with them. And as soon as they're able, try and get them back out into church to integrate them. They might only be able to stay for a little while. You might have to think carefully about that, where they might sit, be sensitive to that. They might need to kind of leave. They might not, they're going to struggle with this, especially when they're very ill. But do help them, try and engage them. As I said, we're psychosomatic, relational beings, and our depression affects us wholly. We don't want to be there, even though we want to serve the Lord. You've got that conflict. Encourage them to overcome that, to be there with the Lord's people. Support them in being there. Next slide, please. Then there's that wider group of moderate depressed people with more moderate depression who might end up in hospital, or they may not, but generally it wouldn't be appropriate for them to be in hospital. They can normally be effectively treated with standard antidepressants and perhaps with cognitive behavioral therapy or some other form of psychotherapy given by specialists. By specialists here, I don't mean people like myself or even psychologists, people who've got some training in this and maybe based in primary care, maybe based in secondary care. But through a combination of a psychotherapy and antidepressants, this can be effective. Antidepressants are very effective drugs when you give them to the right people. Like all drugs, if you give them to the wrong people, they're not effective. And that's one of the problems when you get reports in the media about them not working. It's because, they don't work because you're giving them to the people who don't have depression. So, of course, they don't work. What do you expect? It's like giving drugs that lower your blood pressure, antihypertensives, to people who haven't got high blood pressure. They're not going to do anything. They might do harm. Okay, so for moderate depression, next slide, please. So it's pretty much the same thing. Again, this is something that needs beyond what we can provide ordinarily in churches. They need secondary care. They need specific treatments that are given by secondary, usually primary care. But they also need the same sort of support from, us in churches to visit, to ask these questions, encourage them to come to church, encourage them to pray. It's difficult. They can't read the Bible because of the impact on concentration. Keep it short, keep it focused, remind them of fundamental truths, and do ask about these things, about their miserable thinking, their guilt, and their suicide. Next slide. And then there's this much larger group of milder depression who do not need antidepressants, but are very commonly given antidepressants and then they don't work. Okay, so there's much wider group. And there are various forms of other therapies, psychotherapies that may be used with some level of evidence for help. Next slide. So stepped care is an approach that's used generally, again, in medicine, where you try to titrate the level of your input to the needs of the person, the needs of the patient in front of you. So here, when we talk about mental illnesses generally, this is true form, we're focusing on depression here as an example of this, really. Because we're made in the image of God, we're made to be in relationships. Supportive relationships matter, and they're therapeutic. Okay, take a depressed person, stick them in a flat on their own, of course they're going to get more depressed. Okay, that's what we've got going on at the moment, sadly, with all the restrictions with coronavirus. So people need relationships, and of course, even with all that's going on in the legislation, I've got to be careful what I say, then you're allowed to visit people for this kind of reason. You can visit people to help give care when they're struggling. It's important to remember that. If you know people who are struggling, you're allowed to visit them, and that's important to support them. Again, this isn't anything special. You don't need special training. You need to be a caring, compassionate human being who will go and support the person when they're struggling with their depression. Encourage them, because again, as image bearers, we're made to be active and doing things. So encourage them to try and do things. Think with them, what can they manage to do? What activities can they manage to do that will use their imageness in that way that we're made to express ourselves? So encourage them in relationships, encourage them in activity, useful work. Yes, you've got to eat properly, you've got to diet properly, you've got to sleep properly. These are fundamental things. You remember that when I ran through the features of depression. Disturbance of sleep is fundamental to depression. Disturbance of appetite is fundamental to depression. Disturbance of movement is fundamental to depression. So, you try and engage in those ways. So getting a proper sleep pattern established with so-called sleep hygiene. You can look that up. We're not going to deal with that in detail. But the principles are, you can help somebody deal with these things. You do not need to be a medical or any kind of healthcare specialist to support people in this. And yes, alcohol and other substances do adversely affect moods and function. And yes, Christians do misuse these things, okay? So it can be sensitive, and it may be appropriate for a minister, an elder, be the one who explores this, but you should ask about abuse of these things, because you might be surprised, okay? Probably not, but if it's there, it's something that needs dealing with. And you need to handle it sensitively, but people do misuse substances even whilst they were confessing faith in Christ. Next slide, if it's the right one. Can you go back to? I think they got out of order. So this is just that thing about. So I've said I think there is, a severe melancholic type with the two smaller circles. It's distinct. These are illnesses that will affect anyone. You can't do anything about them. Just like you're going to get cancer, you can't do anything about it really. You can reduce your risks with all sorts of things, but fundamentally, you might get it. And it's not your fault then if you get it. You get, a heart attack or a stroke. It's not because, you did something wrong. You had it because it's an illness. It's the same with these. Psychosomatic illnesses, to some extent, they're more modifiable if you can modify your lifestyles, your patterns of behavior. But fundamentally, again, then there's something that happened to you. That's the external cause of stress, fundamentally for these illnesses. And we all have vulnerability. So the easy thing, I think it's easier if you see someone who's severely depressed, I think, unless you're really prejudiced, you would recognize this person was sick. Okay, it's not so easy to recognize somebody is sick in this kind of psychosomatic, this neurotic category. I think they still are ill, they still need help. But these are the kind of people that are most easily dismissed. Okay, now these are vulnerable people. They're vulnerable by the way they are, by the way you might be, the way the Lord has made you. Some of us are more robust, mentally, physically, to the stresses and strains of life. And other people are weaker and more likely then to struggle with the stresses and strains of life. They're psychosomatically vulnerable people who get depressed, get anxious, and so on as a result of this stress that they're under. And for those of us who might be the stronger ones, who can carry on functioning very well when all sorts of things are going on in our lives, we might look at somebody and say, well, come on, when I was like that, when I had that loss, when I was made redundant, I didn't behave like that. And you kind of blame the person for failing to manage themselves, and it's really kind of their fault that they're struggling. But it isn't their fault. They're made like that. Some of us are made with much more emotional stability and strength than others. And we can bear the strain much better. And if we are like that, we thank God that we're like that. Because if you're not like that and you struggle under these things, that's a horrible thing. Because when these things happen, you become depressed and anxious and you struggle. And you need help. And you need the same kind of stepped care help that I was just talking about, all that input that I was talking about as well for the more severe forms of depression. You need that support to help you through that time. And it isn't your fault, because that's how the Lord made you. We all have our own personalities with our own strengths and weaknesses. And some of us have a proneness, a weakness, a vulnerability to these kinds of mental illnesses. Next slide, I think we jumped to. Next one, thanks. So I think this might be finally. Family support's crucial, okay? So on the one hand, of course, the depression has a negative effect on the family members. It's really hard work living with and looking after somebody with a depressive illness. So it has a big impact on husband, wife, children, the family close to the sick person. So remember that, yes, we remember the sick person. We want to help him or her through this in the sorts of ways I've outlined. But also, do remember the family around who've got to bear the load and what might struggle with. It's draining for them. And so support from people in the church generally is helpful. And in the book I've written about, mature Christian men and women can provide this sort of help. Don't be scared off by the fact that it's a depression or a schizophrenia, it's a kind of mental illness. You can provide meaningful help. And it's a long job. Because these are long-term conditions, it's not kind of a couple of visits, and that's it sort of thing. It can be that if you're visiting somebody who's got the flu or coronavirus or something, the COVID, they get through it, a couple of visits helpful, that's it, job done. Not the case with depression, not the case with mental illnesses generally. It's a long-term job to help people through over an extended period. Long-term support for the patient, long-term support for the family. And I think that's the last slide on this. It is, okay. So I think we're now open to questions.
Thank you very much, Alan. I did appreciate your hard medical perspective on these things. I think it's really helpful. But I did want to ask, you say it's not their fault, if you like, when you have neurotic depression. Is it ever their fault? In other words, would you like to identify spiritual circumstances when that leads to genuine depression?
So I suppose when somebody, you're beginning in a situation where somebody is depressed, and you look at them and you think, well, I told them not to do that. I told them not to engage in this relationship, which has now fallen apart, for example. You counseled them, you advised against it, and now it's fallen apart and they're in a mess. And you can think, well, if you do, it's your fault, because if you'd listened to what I'd said and other people had advised you, you wouldn't be in this mess you're in now, would you? So it's just that's, it's not the most helpful thing, of course, to say at that point, is it? So I think, you want to support them through it without emphasizing that at that point. And then sometime further down the road would, I think, be the time to come back to that and revisit and say, let's think about how that happened so we can help you to avoid that in the future. And, in terms of principles, if a brother or sister in the Lord advises you about something, do think carefully about, whether you should do that. Because last time round, when you didn't listen to what they said, you ended up, depressed and struggling and unable to cope for some months. So, yes, people do get in these situations, and you can look and you can say, it was kind of her fault because, they chose to do this thing they were advised against, etc. So, that's why I was saying for the psychosomatic ones, I think I said, there's an element in which, you can modify it by changing, the way you choose your life options. And I think, we want to help people to choose the right life options. They avoid that because the person who was like that, where they fall apart a bit when the relationship goes wrong, is that vulnerable kind of individual. Their personality structure is such that next time they encounter a stressor, they might well decompensate, go into depression, anxiety again. And so, it's helping those people in particular to be aware that that's how they are. It's not their fault they're like that, they're vulnerable, but they need to recognize they're vulnerable and be especially careful to avoid things that might trigger them and push them into not coping, being ill again. Okay, good morning again. So on to another very large subject to cover in a not very long time. Next slide, please. So I'll start by just quickly overviewing dementia and then focusing on issues for pastors and people in the church. So next slide, please. So what are we talking about? So dementia then is a clinical syndrome, and we discussed diagnosis last time. In this case, then you need evidence then of multiple impairments in what's called cognition, that is aspects of mental functioning, so how you learn things and remember things, how you see and perceive the world around, how you hear, how you process language, how you deal with shapes, how you plan and reason, all aspects of mental function that's to do then with learning and applying ourselves in the world. So you've got objective evidence of this. So in other words, it's not just a memory problem. Memory failure is prominent in dementia, especially in Alzheimer's disease, which is the commonest cause of dementia, but it's much more than memory problems. There's all sorts of other dysfunction that happens, and that it's important to bear in mind, because one of the things that you can do is you're speaking to somebody with dementia and you say something to them and you think they're not paying attention, and they may not be paying attention because concentration can be impaired. You think they're not paying attention, they're kind of ignoring you, being rude because of the way they respond, but it's actually because they can't process the language. They can't actually understand what you're saying. So it's not necessarily, that they're being rude. They might be being rude, they might just poor concentration, but there's these other aspects, and that's one of the difficulties when you are engaging with somebody with dementia. There's multiple things that go wrong that lead to multiple problems with the way that you relate to other people when you're the person with dementia. And then this development of these cognitive problems, the memory loss, the problems with language and seeing things and space and everything, all that then is a change. So people who can be born with a degree of brain damage, and we used to call them mentally handicapped people, or then they were called learning disability, and it's one of these PC terms that keeps changing. But you can have that from when you're young, and that's the same sort of problems. But dementia occurs in people who did have healthy brain function into their adult lives, and then that brain function gets damaged for some reason and they decline. And that decline then leads to an inability then to function normally in the world, that gets very profound, severe. And we would say it's not explained by delirium. So they're not acutely ill with an infection or some other illness that's affecting brain function, but when that other illness is treated, it goes away. It's not that. That's very common, especially in hospitals. It's not that. It is something that's there long term. It's a chronic condition. Next slide, please. So as you'll know, it's extremely common. We give lots and lots of figures. So, it's hugely common. 850,000 is the usual figure given at the moment in the UK. It's going up and up as the population ages. And sometime in the next few years, it'll reach 1 million plus. It costs huge amounts of money. You get figures like in the UK, it's like the size of the Turkish economy. It's a huge amount of money that it costs to look after people. So, for example, it costs more than heart disease and cancer put together. That's the kind of burden of dementia in this country. It's very common. 1 in 14 is a kind of standard figure at the moment for people over 65. It goes up. It's about 1 in 3 by the time you get to people over 80. And actually the same number, because of increasing longevity, but unless we get treatments for dementia that modify the diseases, 1 in 3 born today will get dementia at some point. So that's not a thing that you would tell people who've just had a newborn baby. But, it's how common the condition is. Next slide, please. Now, dementia is very commonly assumed to be the same thing as Alzheimer's disease. So people often use them interchangeably. Say he's got Alzheimer's or he's got dementia. They're not the same. Dementia is what I've just said, and it's due to different diseases. Now, Alzheimer's is the commonest cause. Most people who have dementia have Alzheimer's, but lots of people with dementia have it for other diseases. Next slide. So there's all these other causes. Now this is, I run a national network of brain banks. That is where people who've died have donated their brain tissue. It's been looked at under the microscope, and the cause has been worked out of why they had dementia. And this is something that's just published about now. It's just being published. So about half the causes are Alzheimer's disease in this study, which is lower than is usually said. But that's because Alzheimer's contributes to a lot of other diseases where there's other pathologies, other diseases going on. So lots of people have more than one disease in the brain causing their dementia. So Lewy body dementia is the second commonest cause. It's not usually recognized as such. Vascular disease is generally said to be very common. It's not as common now as Lewy body disease. That's for different reasons I won't go into. Mixed causes are very common. The point here is simply that dementia isn't the same as Alzheimer's. There are different diseases, and these different diseases do have different patterns and have different treatments for some of them then that we use. Next slide, please. So diagnosis. So lots of people with dementia aren't diagnosed still, though that has improved a lot in the last 10 or 20 years. But somebody needs to raise the problem. You know, somebody's getting old, they're struggling a bit with remembering things. And nowadays there's more of an awareness, well, are they developing dementia? But still, you know, somebody needs to bring that to medical attention. Somebody needs in the family, or the patient needs to say to the GP, I think this person got memory problems, they may be getting dementia, and they need then an assessment in primary care. They then get referred to people like myself in secondary care who do a medical assessment. We might do some brain scans and so on, and we then say, yes, you know, she has got a dementia and it's due to, looks like it's due to Alzheimer's disease, or it's due to Lewy body disease, whatever we think it is after our assessment. So somebody needs to raise the problem, comes to medical attention, gets diagnosed. Next slide, please. Now, dementia is defined and diagnosed, as I said, in terms of what we call cognitive problems with memory and learning and use of language and seeing shapes and thinking. But the worst problems for people with dementia, and the worst problems then for their families, are not actually the memory problems and these other things. They can be difficult, but the major problems are the other aspects of the physical impact, and especially the disturbance in behavior that occurs with dementia. These are the things that really stress patients and their families. Next slide. So dementia can cause any kind of psychiatric symptom. So one of the things I used to like asking students was, what's the commonest cause of, you know, hallucinations? And they would usually say schizophrenia, and it ain't, because dementia is a more common cause, and probably delirium is as well, actually, in hospitals. So, but hallucinations are common in people with dementia. Delusions are common in people believing false things, or I should say, hallucinations means, visual hallucinations means seeing things that aren't there. Auditory, hearing hallucinations means hearing things that aren't actually out there and happening. Okay, this is psychosis. It's having experiences that feel like they're in the world out there, but they're not actually real in the world out there. And we'll obviously think on this more when we look at psychosis in the future. But psychosis, depression, anxiety, any kind of obsessions, any kind of symptom that you can think of in any mental illness occurs in people with dementia. Some are much more common, so apathy, for example, is extremely common in people with dementia and very frustrating. So somebody's apathetic means they've lost their drive to do anything, and so they will just sit and do nothing, very, very little. And this is because of the impact of the dementia, the diseases that cause dementia, on the part of the brain that normally gives us our drive to get up and do things. So we kind of take it for granted that something interesting we get up and do. But that depends on parts of our brain functioning normally that underpin that drive. And that drive is just damaged in people with dementia, so they don't have it. So they just sit there and don't do anything, and it's extremely annoying for carers. So I often say, look, it's not his fault. He's not being difficult. He's not being lazy. He's not ignoring what you're saying. He's ill, and he's lost the drive. So you've got to try and encourage him and externally try and provide some of that drive that he doesn't any longer have himself. Don't get annoyed. Try and encourage him to do things. But apathy is a big problem, as are these other things. So shadowing is where somebody typically with more severe dementia will follow the person, somebody else around. So if the husband has dementia, he just follows his wife around the house all the time, which is extremely annoying, okay? And people get, and it can lead to aggression. It can lead to aggression because it's so annoying. You know, that's why it's called shadowing, because they're just always there. They're just kind of stuck onto you. And it's very difficult. Wandering behaviours, again, very common in people with more advanced dementia. So on the one hand, yes, apathy can be very common, but then you get people who just won't stop moving. They just move constantly round. So in modern hospitals, in modern hospital wards, and if you look on nursing homes, you try and design them so that people can move continuously round on a circuit on the ward. Because when these people with drive, so instead of with apathy, you've got no drive, or very little drive, you don't do anything. With this, you've got a lot of drive, and you need to keep going. So if you walk down a corridor and you hit a door, you get very annoyed because you want to keep going. Now, you and I would think, I've hit a door, I need to turn around if I can't get out this door and walk the other way. But they don't do that. They just get annoyed that they can't get through the door because their mental function isn't very good, and they're driven to keep moving, and so they get agitated as a result of this wandering that's obstructed. So on wards you build them so that they don't get obstructed. And then sleep disturbance is very problem. So my point here is that there are a whole series of very difficult behaviours that people develop with their dementia, and that aren't what you use for diagnosis. We think of dementia in terms of memory problems, and yes, forgetting things can be annoying, etc., and is a problem, but these are the worst things. These are what really causes difficulties in families and people who are caring for people with dementia. Next slide, please. So some of these problems are quite severe, okay? So if you've met people with dementia, you try to help them. They become aggressive, they will be rude, they will swear at you. Sometimes they will harm themselves. Sometimes it's difficult to understand why they're doing this. Punch doors, headbutt walls. It's an expression probably of the internal distress and frustration. But obviously it harms themselves, and they harm other people when they get aggressive. They hit out, punch, bite, scratch people around them. Next slide. And then there's the sort of, if you like, the basic physical health burden of trying to care for somebody with dementia when bodily functions begin to fail. So, when you're healthy, you take it for granted that you can, eat your food, you can take your drink. When you've got dementia, you can't do those things. You need help with eating and drinking. You take it for granted that you will put on the right clothing and clean yourself up in the morning. People with dementia don't do that. They don't change their clothing at all, and therefore can become dirty and smelly. Or when you want to try and change their clothing, it can be difficult to persuade them to do that, and that can lead to confrontations and aggression. Again, we take it for granted that we know when we need to go to the toilet. People with dementia lose an awareness of that, and simply therefore, as it were, go to the toilet where they are, rather than actually on the toilet. And these sort of problems with people with more severe dementia occur all the time. Okay, once you get to this stage, they don't go away. You don't get somebody who once was incontinent and now they've kind of improved and it's gone away. It's not treatable in that sense. Okay, so the burden, the physical burden of caring for somebody who needs this level of input 24 hours a day is very hard on people who are living with them and looking after them. Next slide. Okay, so how do we help? Try and help, just very briefly from the medical side. There are now a couple of classes of treatments that we use for people with dementia, that is specific treatments for the causes of dementia. They're of modest but significant help. There is as yet no new treatments since about 20 years ago. And we hear from time to time in the media about some new treatment that's going to be allegedly a cure for Alzheimer's. There isn't anything in the offing. Even the aducanumab, which is being put forward at the moment in America for licensing, is really a very modest, if real, effect at all. So for the time being, we haven't really got treatments that will cure or even stop the progress of dementia. We've got some treatments that help people a bit with their memory and their hallucinations and so on. A lot of the treatments we give are therefore focused on those symptoms to try and treat the depression or the anxiety or the agitation, not the dementia itself, the disease, and not the memory and the concentration, but other aspects. And this is important to treat these things because these are horrible experiences for the patient and horrible for the family looking after them. So once we've made a diagnosis and we look to use these sorts of treatments in collaboration with people in primary care, people then need support. Usually now we'll diagnose people relatively early. It's in my time as a consultant, we've moved to diagnosis 2 or 3 years, maybe 4 years earlier than we did. So people are much earlier in their dementia than they were. And so it's at a stage where you can help somebody think about their future with dementia while they're still able to some extent to think and plan about that. So, you want to get fundamental things about, what's called care planning. So sorting out, making sure they've got a will that they're happy with, lasting powers of attorney, that they think about who they want to care for them, where they want to be looked after, and so on. So you want these things sorted out, and obviously provision of information for the patient, for the family, so they understand something of what it means, this disease that they've got and this dementia syndrome that they've got as a result. So these are sorts of things we do in the health service. Next slide, please. So as well as those things, then also there is, the need for psychological support. This is earlier on, you want to help the person come to terms with the diagnosis, to understand what it means, to support them with some of these problems, depression, low mood, anxiety, and so on. Carer assessment should be part of what happens with a dementia assessment. That is for the immediate family largely, to support the family, those who are providing the care. Care in a lot of people is provided not by family members, because a lot of older people live on their own, and therefore they have carers who are paid to do that work from outside the family, and that's important and good. And they may get help at day centres, though these are all being closed nowadays, and they're not open at the moment anyway because of COVID. And then there's sort of respite care, so when people get more severe with their dementia, you can put people support for periods of time away from home to give a period of rest and recuperation for the family, and some rest for the patient away from what can be a difficult home situation. Next slide, please. As you'll be aware, a lot of people, but not everybody with dementia, goes into nursing homes. There are different levels of nursing care. One of the gratifying experiences for me in my time as a consultant is seeing the nursing homes improve in quality, seeing an awareness of dementia become, pretty standard among carers in nursing homes. There's a lot of work that, was done 15, 20 years ago to teach people in care homes about dementia. I used to go in and they would say to me, we just tell her, go and eat her food, and she just doesn't listen to us. And they had no awareness that this was because the person had dementia, and that she either couldn't understand the language that was being used or simply couldn't remember afterwards what they were asked to do. But that led to kind of bad relations with the carers, because they blamed this person for ignoring them, because they simply didn't understand about dementia. Now, I don't have that now, I'm glad to say. They understand these are sort of fundamental. The person's not being difficult, awkward, or rude to them. It's their dementia. And it's why it's important for dementia diagnosis to be made so that the carers can then understand and respond appropriately. Now, if you have a person with dementia in your family and you've then been working to support them and provide all this care that can be extremely difficult as the health burden increases, the physical burden, the difficulty in managing their apathy, their agitation, whatever it is, then it may be necessary for your loved one to go into a care home. And a lot of people, and I suspect especially Christian people, think that if that happens, you've kind of failed. Okay, you say, I should have been able to manage him. I told my husband, till death us do part, I will always be there for him. And he said to me, I never want to go into a care home. And I said, I won't let you go into a care home. Okay? This is what happens. But it simply isn't possible to manage people at home sometimes on your own. Obviously, in past societies, there was a wider network. But in our society, with kind of our isolated, smaller family units, one or two people can't manage a lot of people with dementia because of the burden of the illness that they have. So the fact that somebody goes into a nursing home does not mean that the people looking after them at home have failed. It's something that simply can't be avoided a lot of the time. And within nursing homes, there are different levels of nursing care and other care that can be provided, which I won't deal with. But, you don't, from being on your own or being with a family member or with your family, it's not just to what you might think of as a nursing home. There are other lower levels of residential care that can be provided. Okay, next slide, please. So trying to move then to issues for pastors in particular and people in the church. Next slide, please. So again, as with depression, I said, as with other mental illnesses, do encourage people to come to church, do encourage them to engage. They might be apathetic, they might be low in their mood, they might not want to come, they might, as I say, because they're apathy, not the drive to do it. That's not because they're sinning or being bad, it's because they're ill and they've lost the drive to do this, and they need encouragement and support to get there. And of course, when they're there, you need to think about again where they're going to sit in the congregation. Generally not a good thing to put them near the front of the building or in some kind of prominent position because they might become distracted or distressed. And therefore you would want somebody at a position where, if that happens, they can easily be supported without it disturbing the rest of the congregation and perhaps taken for help outside the worship area. So, thoughtful positioning. And clearly you want people with the person with dementia whom they know. They struggle to remember who's who, but at least maximize the chance that person will be able to support them because it's somebody they recognize and know and associate with the church and so on. Familiarity. So, one of my irritations with sort of changes in worship and how people do worship is it's actually very cruel to people with dementia because we get used to, we're people who do well with habits, we get used to activities that are predictable. We come to a service, we expect it to be in a certain way, a certain order. And if that's changed around, that's very distressing actually to the person with dementia. They're used to singing this hymn, and now somebody's gone and changed the tune. They're used to singing this hymn, and somebody's gone and fiddled with the words. And that's annoying, it's distressing to people with dementia. Now, this isn't an argument for certain styles of worship, but it's just saying that you've got to think about what you're doing, think about people beyond your own group, think about the impact on other people, including people with dementia, when you go changing things around, because people with dementia struggle with change because of the impact of the dementia. And so, you might need to tactfully help somebody in the church, to support them in following the hymn, changing the pages, following the reading, open the Bible for them. They might not be able to read it, but nonetheless, there's an assurance of having the open Bible because that's what they're used to, and so on. So it depends very much on the individual and you knowing them and supporting them. Next slide, please. So the causes of dementia are causes which lead to death. Dementia is a terminal illness, or it's due to a series of terminal illnesses, if you prefer that, the different dementias. And so when somebody gets dementia, they are dying. Now, I know we're all dying one level, but, they've only got a few years to live, okay? So you become aware of that, and you've got to adapt to that if you're living with a person with dementia, and the person with dementia has to adapt to that themselves. They've got a terminal illness. And it's important always to think of dementia as a terminal illness, okay? It used to be very rare when I was in medical school. You might have had the same, Chris. It was rarely put on death certificates that Alzheimer's is a terminal illness. Lewy body disease is a terminal illness. They kill people. And people change, okay? The impact of the dementia on the behavior means it's difficult to relate to them as you once did. At one level, this is the same person. This is the husband you married or the wife you married. And yet at one level, you're aware that they're not the same. You find that they can't remember those things you used to do together. They can't share with you in those happy memories from the past. And that's difficult. They're losing that. So it's not, as it were, just that they've got a terminal illness, which they have, but it is that the terminal illness directly changes the person and necessarily their relationship with you. Because as we said earlier in the previous talk, we are made in the image of God. We're made to be in relationships. When I'm damaged, that affects my relationship with the people who know me. Next slide. So grief is something that goes along with dementia because it's a terminal illness. So one thing this means is that by the time the person dies with dementia, a wife or husband left behind might actually not feel much grief at the end, because they've had years of being with a person as they've died. And so they're coming to terms with that along the way. But it also means that the grief might be worst, most impactful near the beginning, when they realize that this person is dying. That's the time when it might most impact them, and they might feel and struggle emotionally with the knowledge now that they're losing the person they love. So, that this grief, the pain of the grief might occur quite early, and commonly will not occur much towards the end as you've adapted to the situation. So you don't necessarily have so-called normal grief when the person dies. And that is then, of course, not because you didn't care for them, it's because you've learned to adapt and deal with it over the previous months and years. Next slide. So as somebody gets dementia, then they lose memory of things, including what they've learned from the Bible, including all that they have learned about the Lord and salvation. And roughly speaking, you lose the most complex things and the most things you've most recently learned earliest, and you hold on to those more basic things. But of course, we're not saved. Well, we are saved by our faith, but ultimately it's by God's grace. And it's an interesting thing, I think. I've never read anything on how Arminians deal with this theologically. But if it were true, that I have to continue to know, to trust in the Lord by my own understanding of my sinfulness and my own conviction and my own faith, then that seems to me to mean that once people reach advanced dementia, they lose salvation because they're no longer capable of expressing such faith. They no longer have that knowledge of the Lord that leads to salvation. But of course, we know that isn't the case. We know it's ultimately the Lord's grace who has regenerated us. And the fact that I can no longer, with my severe dementia, confess faith in Christ, the fact that, if you ask me, are you going to go to heaven? I can't even understand what the word heaven means. Doesn't mean I'm not going to go to heaven, because I go to heaven because of Christ's death for me and his resurrection for me, and the faith the Spirit gave me in him and the relationship that's brought me to him, not because of what I do. It's by grace we've been saved, and therefore, people with dementia lose awareness of salvation, and that can be very difficult. But it's also fragmentary, so people will remember certain things, remember certain verses from the Bible, remember certain truths, remember certain hymns, and so on. And, you can find those things, lock onto those things, and encourage them, engage with them with those things. So, there are things that people do remember, can encourage, even when they don't understand anymore. So the fact that somebody is unable to express that relationship, obviously they still have a relationship with the Lord. The relationship with the Lord is not lost because it's from the Lord as well, and at some level I think they continue to experience that, and my biblical justification is John the Baptist in the womb, who even at that age when he wouldn't seem to have had the mental function to, as it were, engage with the Lord, nonetheless has a relationship. Because a relationship isn't ultimately dependent on my cognitive function. And a relationship that you have with a person with dementia, it's two-way, isn't it? So the person with dementia now is unable to express their relationship with you. They're unable to express their relationship with the Lord. But from your side, you can still love them. You still relate to them. You can still speak and encourage them and seek out ways then to support them and to get through to them. And people pick up body language even when higher mental function is very lost. So the fact that somebody can't answer questions, and answer the catechism and all of that, doesn't mean that they don't relate to you. And it's one of the things you need to say to people, and you learn to tell people who are caring for those with dementia is, he might not understand what you're saying, but he can feel or sense, he knows how you're reacting. So if you were being rude and dismissive and talking in front of him, he knows that at some level that's kind of beyond language, that's to do with the way we relate fundamentally. Just like babies pick up things, people can pick up things. It's not necessarily, you don't have to have the cognitive ability to express and explain. You pick that up. And so it's very important then when you're engaging with somebody with dementia to keep giving the input from your side, even when you don't feel you're getting anything back from their side. And that's how God deals with us. He keeps giving to us even when we don't give back as we ought to do, and sometimes don't at all as we should from our side. So relationships, ought to be two-way. There ought to be engagement on both sides. With dementia, at some point they might not be able to be like that, but you can still relate and support somebody. Next slide. So there are certain things that people don't talk about with dementia, okay? Particularly with its dementia and Christian people, okay? So they don't say that he wanders around and he swears at me. Because he's been, an elder in the church for 30 years, and he never swore. But he is now. I don't say he hits me. He's always pursuing me, shadowing me around the house and hitting me. It doesn't matter what I try and do, he's aggressive to me. He follows me around and he molests me sexually. And you might be the daughter, not the wife. The daughter is trying to care for your father, and he gropes you. And people don't, of course, say that because it's so difficult to say. And I'm not saying that they ought to be saying that, but I am saying that you, if you're trying to help people with dementia, and especially the family members who are suffering like this, be aware of it. And just as I was saying, I'm asking about suicidal thinking. Let's seek an opportunity to kind of ask about some of these things that might be going on. Because otherwise the person's completely isolated because they can't tell anybody about these kinds of things, which are horrendous for them to experience. So it's not, again, because having asked, you're going to give an answer. It is because having asked, you can then show that you are sympathizing and supporting them. There isn't, a magic answer that will make these things go away. Certainly not one that you can provide. I can provide certain treatments to modify some of these things, try and help with that. But fundamentally, from your point of view, it's supporting the person who's supporting the person with dementia by being aware and being willing to talk about in private, in an appropriate situation, some of these extremely difficult issues. Next slide. Okay, so somebody asked before about personal responsibility. So, of course, I've left this till I've only got 1 minute left. So personal responsibility. So Andrew Sims was a Christian psychiatrist present at the Royal College some years ago. So he said, in trying to decide what is and what is not mental illness, it's useful to consider different dimensions. For example, contrasting the mentally ill and the mentally healthy. So that's what I was doing before. What do we mean by mental illness? How do we distinguish that between mental health? But an entirely separate and independent dimension is good, bad, and right and wrong. We don't define mental illness in terms of moral behavior, which goes to one of the questions that was raised earlier. This is a different construct or a different concept. That these variables are independent of each other is obvious, but it does need stating. Okay, next slide. So mental capacity then, that is how much one understands about what's going on, and therefore how much can they take responsibility for what they do in the world. Okay, so mental capacity, we're talking about the mental ability, the capacity to understand and take responsible decisions for our actions and all our behavior. Okay, so if you just go to the next slide and we'll come back again, I think. I never know which way around to do this. So mental capacity is not binary. That is, it's not you either have it or you don't. Often people speak like that and they say, does he have capacity or not? And that's a wrong question. It's does he or she have capacity for this decision? And decisions vary in how easy or difficult they are to make. And one of the things, so the hardest decisions are on the left side here. And of course, being a consultant, I think one of the hardest things is to make decisions as a consultant. But, there are certain decisions that involve digesting, taking in and balancing up lots of different pieces of information, lots of different conflicting pressures and so on. And you've got to weigh all that up, being a chief executive. There are sorts of responsible positions, very high level. And you don't have to have much of a mental illness to be able to not make those kinds of decisions. Okay? At the far end, or towards the far end, we'll come back to moral, it's kind of marriage. It's well recognized that marriage, in terms of capacity, is an easy decision. Okay? Now, I mentioned marriage to make the point that it isn't, whether a decision is easy or difficult, is nothing to do with the importance of the decision. Okay, I think we'd all recognize that deciding whether to marry someone or not is an important decision, but that doesn't make it a difficult decision mentally. Why? Because, from the time we grow up learning about what marriage is from when we're children. So all our lives, we learn, we know what marriage is, okay? So we have to then lose a lot of mental function to no longer be able to understand what marriage is, okay? That's why marriage, although it's an important decision, is an easy one to make because we all have a good grasp of what it is. So if you think about taking an antidepressant, I've got, a medication I've got towards the easier end compared with having surgery, okay? Because most of us understand, I could take an antidepressant, I could take a drug, the doctor says take it for this condition, and that's not a difficult decision to take, okay? But it's much more difficult to understand, some kind of surgical procedure, because you've got to know a bit more about what it means, what exactly is the surgeon going to do to me in cutting me open and so on. So that's a more difficult decision to make than taking a drug. So in terms of dementia, understanding where you want to live, who you want to look after you is an easier decision than taking these medical decisions about treatment. So it's sort of trying towards this end. In terms of, so I've put there, where is it? Oh, it's disappeared. I had LPAs on there. So making a will and then a lasting power of attorney, they're in the kind of middle area, okay? So making a will is a bit easier because most of us grow up, we know the idea of making a will, it's leaving, my possessions to people I want to have them. A lasting power of attorney requires more mental function because we don't grow up learning about lasting powers of attorney. But it's not that difficult because it means that I'm asking this person to take care of my finances while I'm alive, or I'm asking them to make decisions about my care while I'm alive. It's not that difficult, but it's more difficult than making a will. Okay, so the principle is different levels of complexity, not binary. It's not a yes, no, has or doesn't have capacity. And in the Mental Capacity Act, we all, under the Mental Capacity Act, are able to make decisions about somebody's capacity. Okay, you don't have to be a consultant psychiatrist, you don't have to be a doctor or a nurse. Everybody is making decisions about the capacity of people to make decisions in their lives. Family members make these decisions, okay? Now, if you just go back a slide again. So moral decisions then, remember I put moral at the farthest end, okay? Because moral decisions are very easy. In the same sort of way as we grow up learning about what marriage is, everybody grows up being told what's right and wrong. That you don't swear at people, you don't hit people, you don't steal things from people and so on. Everybody is taught about these things from their earliest years. And therefore, you have to lose a lot of mental function to no longer be able to understand the difference between these, what's right and wrong in these sorts of things. Okay? But more than that, of course, we know that the Lord, as having made us in his image, has put his law within us. That written on the hearts as image bearers is the law of God, telling us what's right and wrong. That is how God is, what he says is right and wrong. So as image bearers, every human being knows these things. We're all brought up being taught these things. Yes, they don't exactly correspond from people out there to what the Lord says is right and wrong, but the principle that you know what's right and wrong is there, it's written in us, it's taught to us, it's drilled into us. So it takes a lot of loss of capacity to remove the ability to make a decision about right and wrong. Okay? So people with mental illness, the great majority of people with mental illnesses are able to make moral decisions. People with mental illnesses, by and large, are responsible for their actions. They're not absolved from sin because they've got depression or schizophrenia or something. They're responsible. Now, when those illnesses become very, very severe, and with dementia, when dementia's severe, then they no longer know those things, what's right and wrong. So it's possible for people with mental illnesses to lose capacity to know what's right and wrong. So this man then who's following his wife around and groping her, okay, doesn't understand what he's doing. He's lost all sense of what this means, okay? He's not responsible for his actions. And therefore I'd say he's not sinning in doing this, okay? He is no longer having capacity because of that. On the other hand, people earlier in their illness, dementia or otherwise, do know what they're doing. They are responsible and need to be held responsible for those decisions about right and wrong. And as I say, most people, my now quite extensive experience, most people with mental illnesses are responsible. That includes most people with dementia. But with severe psychosis, severe depression, and especially dementia, people reach a stage where their mental function is not good enough to enable them to understand right and wrong, and therefore be held accountable for their actions. Okay? And then finally, I think this is finally, so a good Catch-22. Now, Catch-22 is not a book I would recommend by any means. Catch-22, I read it many years ago before I was a Christian, and it's a book about being a pilot, pilots in the Second World War, flying in missions into Italy in the Second World War, and the book's about the horrors of war. It's an anti-war book, and it's about the fact that people didn't want to take on these missions because the mortality rate was so high. And so the joke, the catch-22 in the book is that the exemption from being able to fly as an American pilot into Italy was that you were insane. Okay, if you were insane, you were exempt from flying. If you had to go to the doctor and get signed, as insane. So the guy goes to the doctor and says, I can't fly, doctor, I'm insane. And the guy said, well, why don't you want to, well, I don't want to fly. And he says, well, you have to fly. Only insane people want to fly. So he says, wow, that's a catch, isn't it? Yeah, catch-22, the best there is. Now, it's used generally about things where you can't get out of a situation. So a good catch-22 is, you see, that if somebody says to you, I'm mentally ill, it's not my fault I did that. That means they are responsible. Because if you've got the mental function that's good enough to be able to think like that, that means that you are responsible for your actions. You never get anybody with a severe dementia who says, I didn't mean to hurt them when I hit them. It's not my fault, it's my dementia. Of course you don't, because you need a good level of capacity and mental function, therefore, to be able to claim that you don't have responsibility. So if anybody ever says to you, in my opinion, it's because I'm depressed that I did it, or it's not my fault because I was depressed or anxious, you say, well, it is your fault, and it is your fault because of what I call this good catch-22. If you're aware that you are trying to claim that you're not responsible, then you are responsible, okay? The only people who are not responsible are those who are so impaired that they will never claim that they're not responsible for their actions. If you see people with severe dementia, you see people with severe psychosis, they're completely incapable of making those kinds of claims. They're too damaged by their illness to seek exemption in that way, as it were, from their moral responsibility.